Hello, everyone. Welcome to another VMR morning report. We're very happy to have you here, and we see many familiar faces. Today, I'll be discussing with Dr. Ravi, and we have a very special case presenter today. Henry, how are you, Henry? Would you like to introduce yourself?
Hey, well, yeah, I'm Henry. I'm a third-year medical student rotating here at Sinai with Dr. Kunkun.
Yeah, and Henry, tell us a little bit about yourself. Like, what do you like to do, and what is your favorite cuisine?
Oh, sorry, cut out for a second. But I think just I can give a short. So I'm from Maryland. I go to med school at Hopkins, and I've been in the DMV area my whole life, and I'm applying into orthopedics.
Awesome. And what name a hobby, and we always like to ask, what's your favorite cuisine?
Oh, favorite cuisine, that's pretty hard. I guess I like to work out a lot, and for me right now, what I picked up is cycling. So I rely a lot on my indoor trainer. Favorite cuisine, I don't know. Maybe ramen. I like ramen a lot.
Same here, favorite of mine as well. So awesome. And Yasmin, how you been?
I'm very good, thank you. I'm preparing for a rotation this next month in the higher entry program in infectious disease. So yeah, I think many of you that know me know that I'm very, very excited because I'll be looking at all these topics and bugs and antibiotics, things that I really like. So yeah, I'm very, very excited. How are you?
I'm great. I also saw your comment in the chat. You love Indian food. So interestingly, Henry, we had Indian food over the weekend, right? It was great. So we were on call and we ordered Indian food, and that was great to get some energy to see some more patients. All right. So Henry, the first aliquot, and we'll deploy the whiteboard. And appreciate Deborah and Shema for helping with scribing and teaching points.
Okay, so the first aliquot is a chief complaint. And for this patient, it's altered mental status.
All right, Yasmin, what do you think?
Well, for this approach of altered mental status, I like to think about it as a symptom, but not specifically as the diagnosis. And yes, as Huiting said in the chat, the MIST mnemotechnique helps us a lot, metabolic infectious toxins. But whenever I see that on a patient, if it's not on a rapid response in the hospital, it will be, first of all, check airway, breathing, circulation, and exposures. I forgot about the D one, but I think it's disability, like neurological dysfunction. As I remember Sammy once telling us in one of his very great discussions. And then I would definitely look at the vital signs after assessing the ABCs, look at any possible problems like that could be an emergency. And maybe after looking at that, of course, the differential diagnosis that I'm thinking about will be, is this patient, how is this patient's metabolic panel, hypoglycemia, hyperglycemia, hyponatremia, and so on. Also, what kind of medications is he on? If he is on sedatives, if the patient is, or if he, or this patient, we don't know still if it's a she or a he, but if this patient, if they are on any medication, if it's from home or if it's already hospitalized, see if it's something. Also think about past use of drugs or alcohol. And as well, in an infection disease, if it's an infection, I would look for concomitant fever and think, well, maybe this is, it could be a myriad of infections, but I won't anchor of that. The main ones would be if there's a patient that is also having fever and respiratory issues such as pneumonia, or if there's a patient that has fever and urinary issues, I will think a UTI that is getting decompensated. Also, we don't know the age yet, but that's what I'd be thinking about after the ABCDEs, vitals, the MIST. That's my initial approach of AMS.
Wow, Yasmin, that was an incredible start to the discussion there. And I really don't have anything to add. And it's just very interesting to see everybody approaches this in many different ways. And I just love that you just displayed or you were able to visualize your thinking there. And I'm very interested to see how we can fit the next aliquota data, the HPI, and then the past history to see if we can narrow down things on what you did discuss right there. So back to Henry for the next aliquot.
Okay, so the HPI. So this is a 40-something woman that was brought in by EMS and police after being called to her house by her neighbor for a wellness check. She was found down, lying in a big pile of trash, and notably her home was like that of a hoarder's, where there was trash everywhere, and there were active rats and rodents running around the place. She was found down with vomit on her chest and was completely nonverbal at the time. I think she had gotten on naloxone at that point, but there was no change in her mental status following that by EMS. And then she was brought to the ED from there. Additionally, at the same time, because that patient was completely nonverbal throughout the ED, except the only other thing was that she just continued to have non-bloody, non-bilious emesis. The neighbor was contacted and gave a very little brief sort of history of her. The neighbor said that she had used drugs in the past and is considered a hoarder. The only 2 medications or 3 medications that he thinks she uses, one, he knows she takes methadone. She takes some sort of blood pressure medication daily, says she doesn't use any alcohol, and also takes Xanax or some sort of benzodiazepine pill every day. And he said that her last known normal was at least over 24 hours ago because he saw her.
Very interesting. Should we go over the past history, meds, up to the allergies as well?
Yep.
And then we'll
so
stop
past
the
medical
discussion.
history, from that neighbor's discussion, as the patient is still nonverbal at this point and unable to communicate anything, we know she's got some sort of polysubstance use disorder. She probably has some sort of, or supposedly has some sort of hypertension. Otherwise, it's really unknown. Social history, she lives alone at the moment, is a hoarder, and lives in a really messy, dirty home with active rodents and rats. Otherwise, family history is completely unknown. Surgical history is unknown. No known drug allergies. And the only medications that we know of so far are methadone, some sort of benzodiazepine, likely Xanax, and some sort of blood pressure medication that's unknown.
All right, great. Henry, so well presented. You're such an expert in presenting cases. And so, Yasmin, what do you think? What would you do with this new bit of data?
Yeah, thank you, Henry. This is a very well presented case, and I think it's much easier to dissect the information. First of all, this patient was found vomit on her chest, and we obviously don't know how much time has she been lying around. But the first thing that comes to my mind will be aspiration pneumonia, and I will definitely ask for maybe imaging to see if she doesn't have any consolidation process, because aspiration pneumonia can get quite ugly. And on the other part, I would definitely look at the physical exam. She has a past medical history of opiate use. Obviously, I'm not positioned to think that she has relapsed or using any other opiates. But I will also look for the opioid tox syndrome, opioid respiratory depression, and other clinical features. Like, for example, first of all, she already has the AMS, so I would definitely look at her respiratory rate, look at her pupils. If I'm not wrong, if it's an opiate issue, they will be pinpoint. And also definitely monitor her ventilation markers. And as well, how is her, I'm not very sure if there is a interaction between benzodiazepines and methadone. Right now, I'm not very sure. So I'm wondering if that could also be something that triggered this issue. Because I'm not going to anchor it and this is just she aspirated or it's just opiates, but that's inside of my DDX. What do you think, Dr. Ravi?
Absolutely wonderful there. I really appreciate you stopping at the medications and combing through them to see if they could potentially be a cause of this AMS. So methadone, as you correctly had suggested could cause. You could have an overdose of methadone, and benzodiazepines actually would accentuate any alteration in mental status. So I would be very careful. And then you also have to wonder about within the MIS, you mentioned mnemonic early as well. So drug on and drug off phenomena. So withdrawal would be indicated in this as well. So in the exam that Henry will present, we'll also look for features of withdrawal, whether it be benzodiazepine withdrawal or narcotic withdrawal as well. And then, like you mentioned, with the vital signs, and also lab data would be important to see if this patient may actually have hypoglycemia as well, and the patient's state of nourishment as well. Are they malnourished or not? And then particularly paying attention to the temperature to see if this is may possibly an infection, and also the white count. But at this stage, I think the patient is altered. We don't know why, but definitely reversing potential opioids if patient had ingested excessive amount, and also checking the glucose, and then also then stepping back and looking at the bigger picture to see if there is any one of the metabolic, infectious, structural toxins here. And not to mention, could there be CNS structural disease here? So getting a CAT scan will be imperative to rule out maybe brain hemorrhage in this case. And then this rats running around is interesting that Henry mentioned. So before I kind of comb through rat associated illnesses, what do you think, Yasmin? Anything come to mind with rats?
Like so far with rats, if she is, oh, there are so many. Like the main ones would be leptospirosis. And if there is rats, there will also be other bugs. Then depending on where this patient is, if these rats have fleas or ticks, there will also open a door to all these vector-borne illnesses. But those will be the main ones. Like and also in some places Yersinia pestis, but I wouldn't. That's a very nasty bug, so I wouldn't dare to say it would be that one. And yeah, basically those ones.
Yeah, very good. So definitely, I was thinking we did have a case of leptospirosis with rats, and patients walking, or this patient was walking barefoot and stepped in rat urine. So leptospirosis is a very good thought too. Then pulmonary, I'm not getting a sense of pulmonary involvement, but usually the vignettes would mention a patient cleaning a shed out in Arizona, maybe in one of the desert states, and developing hantavirus. And then there was a VMR probably 2-3 years ago where a patient had a pet rat, which was very odd, and sustained a bite from the rat and developed rat bite fever, which is caused by Streptobacillus molliformis, if I remember. And that would be something you would think about, although I don't think this patient's probably keeping any of those rats as a pet. And then I think there are a few more. You correctly mentioned plague, or in history was known as a Black Death. So looking for buboes due to bubonic plague. So that would also be something to think about. And I think something else you could get is lymphocytic choriomeningitis, which is a viral disease. So something to think about. In this case, this patient has altered mental status. And I'm sure there's many more. Tularemia could also be a disease that could be passed on from rats. But we'll see if that is a contributor or it's a detractor to this presentation. So Henry, back to you for the physical exam.
Okay, yeah, that was very thorough. And I think at the time, we were all thinking many of those things as well. So for her physical exam, when she first came to the ED, her blood pressure was 197/90. I think it stabilized around 150/90, something like that, without any specific blood pressure treatment. She was tachycardic, heart rate was in 100. She had a respiratory rate of 14. She was afebrile the entire time in the ED. Her temperature was on 97, and she was sitting at 100% on room air. I can pause for a second if you let me know if you need to repeat anything. Okay, so then in terms of our physical exam, I didn't particularly see her in the ED, but this is per the resident that admitted her. In general, she was just sitting and staring blankly at the wall. She was non-communicative and her tongue was hanging out. Her tongue did not have any fasciculation. So from the head down, at the head, there wasn't any apparent visible trauma. She appeared to have moist mucous membranes. She had very poor dentition. She was missing almost all of her teeth, if not all of it. She did have some bilateral parotid gland enlargement. Regarding her eyes, they were equal and reactive to light, and they were not pinpoint. They were kind of normal in size. The exact millimeter was not documented. There was no scleroicterus, and there's a little bit of conjunctival pallor. Regarding her neck, there was no palpable cervical lymphadenopathy, and she did not complain of tenderness or did not shout when her neck was touched. Regarding her cardiovascular exam, she had regular rate and rhythm. There were no murmurs, rubs, or gallops. She had a clear S1, S2, and her JVP was not seen, and she had no pitting edema. Now, in respiration, she had normal work of breathing. She was not tachypnic on exam. She had normal chest expansion, and actually had equal breath sounds bilaterally. There were no wheezes, no crackles, no rhonchi, and her lungs sounded very clear bilaterally. Regarding her abdomen, bowel sounds were present throughout. It was soft, not tender. There was no distension. There was no rebound tenderness regarding, and the resident didn't notice any hepatomegaly or splenomegaly. She had good peripheral pulses bilaterally, and the neuro exam was quite limited, given the fact that she was nonverbal, unable to follow any commands, but there was no noted facial droop. She appeared symmetric and the tone seemed normal throughout. Now, her last and most sort of interesting finding was her skin, and a rash was noted that I have. I can share my screen in a second and show some pictures. Basically, there were scattered petechial sort of violaceous papules distributed throughout her bilateral lower extremity, and maybe some hyperpigmentation around her ankles. Additionally, she had all sorts of these scattered and raised wounds throughout her entire upper lower extremity, throughout her thorax or groin, that look crusted and almost in some areas look excoriated as well. So I'll briefly share my screen just to show what it looked like. These were the chronic wounds that appeared throughout her groin, and it was quite, I didn't want to put any body parts that would reveal anything, but this was just on her leg or thigh. But she had this all over her abdomen, her belly as well. And then this was the sort of purpuric violaceous papular rash that was distributed in bilateral lower extremities. You can see the kind of, it was non-blanching as well at the time. They're both lower extremities. And this is the hyperpigmentation that they commented on. So I'll stop there for the physical exam.
Wow, thank you, Henry. The pictures were great. They just help us visualize this rash. Now I'm really concerned. This has taken a very drastic turn. There's many different systems involved, and I'm just trying to piece it together. But I guess I'll comment on the rash, and Yasmin, if you want to take the first part of the physical exam, and we'll see what we can make of all of this.
Yeah, of course. First of all, like this patient is hypertensive, which I'm seeing that maybe it is I don't know her baseline, but I would definitely want to follow up on that. And while it's true that she may be having other drug issues, I wouldn't like to like wander into that if I'm not asking her. The pupils are reactive to light. She's moist mucous membranes. Her respiratory rate is normal. So my first differential diagnosis of maybe she had opiate use, it's out of the window. Now they mentioned the parotid gland enlargement. This parotid gland enlargement, sometimes any lymphadenopathy, any enlargement of lymph nodes make me think, when there are rats involved, make me think of tularemia, because I would definitely see if it's painful or not. There's tenderness. Now her she has a normal work of breathing, normal chest expansion, no wheeze. So again, my other differential diagnosis of aspiration pneumonia is also out of, well, not completely, but it will be really down on my differential diagnosis. She doesn't have hepatosplenomegaly, so there are many diseases that will cause you that issue. But when we go to the rash, the first thing I'm thinking with this background is, what about typhus? Typhus caused by Rickettsia typhi is caused by rat and cat fleas, and it shows a maculopapular petechial rash. I'm wondering, Henry, if she had she had also this rash in palms and soles. If it's not, I would definitely think maybe it's typhus. And although her heart rate is on the verge of being tachycardia, it's 100, and normally these patients have go on the lower threshold. The other, another thing that came to my mind aside from typhus, leptospira, is also another one called melioidosis. I remember that was one of my first cases discussing with Dr. Ravi that was also due to rats. And although it's not endemic, because I'm guessing this patient is in the US, so Burkholderia pseudomallei, it would be very unusual to see it here. So that will be my three suspects. What do you think?
Wow, Yasmin, incredible display of your thought process here. Your mental model is just incredible. I didn't even explore the domain of melioidosis and some of the other illnesses that you had mentioned just descriptively. I think here you have definitely a systemic process. I'm kind of intrigued there's no fever. A fever would really make me consider infection here. And then the rash didn't look overtly angry, erythematous. Some of it, I think some parts of it looked like it was healing over, but there was mention of petechia. And on Sunday, we had an absolutely stellar case by Bea of petechia. And then just revisiting my exploration of that problem, I have to start thinking then, is it something associated maybe with a toxic patient? But I think we're in the domain of a non-toxic patient, then is this something that's a raised petechial rash that would indicate vasculitis? And we explored all the different kinds of small vessel vasculitis as a possibility. And again, this is non-blanchable. And then also to think about capillary fragility. And in that case, it was scurvy that was the cause of that. And then this usually is located in the lower extremities. Of course, you also have to think about thrombocytopenia. So you're thinking of diseases that could also decrease the number of platelets. So you got anything from, if you run the gamut through ITP to tick-borne diseases to any drugs that could lower platelets, just like alcohol use disorder and so on. But again, here, I think this may be a sequela of maybe an infectious disorder again, but I'm not seeing the signatures. My mind's kind of like going to and fro between infection versus inflammation, and vasculitis was one that I had just mentioned, and then coagulopathies, but I don't get that sense that there is also a coagulopathy. Now, I'm not sure some of those lesions that Henry had mentioned had a purple border, and the kind of lesions that may have sort of a purple border like that, or violaceous border, it just kind of escaped my mind, but you can have a pyoderma gangrenosum that may manifest like that. I think Pseudomonas may also have a purple border. Are we dealing with Pseudomonas? I doubt that, but just something to put on the radar screen. But at this point, not quite sure. Syphilis can have a diffuse rash as well, but usually not in this configuration. And then I like the thought, yeah, could this be scabies? You can have Norwegian scabies with a diffuse outbreak. Part of it is healing over. I'm not quite sure if we're seeing the full extent of this rash here. HIV, definitely. Now it came to my mind. So HIV, I would also consider. You have a diffuse maculopapular rash, something to consider too. And we didn't go into the behavioral history if the patient is at risk for this condition. And you can also get a rash with rat bite fever as well. So walking it back. And then I just love the thought of Yersinia pestis with this patient, but I would also look for lymphadenopathy in this patient with some ischemic changes or necrotic changes to the skin as well. So I think calciphylaxis also can manifest with, usually we'll have some necrosis there as well, but you also will have a purplish violaceous border. So those are a couple of things I can think about. And we'll see what the labs, if the labs can help us narrow it down. Obviously, a skin biopsy may be necessary here to further discern what the cause of this rash is. But back to you, Henry. Henry, did you freeze there a second?
Oh yeah, sorry. I think the internet connection here a little rough. So sorry, I missed the last part. Do you want me to go over the labs now?
Oh yes, please. Yeah.
I may switch to Carly's laptop because my Wi-Fi is.
Yeah, like Dr. Ravi, on the meantime, maybe we can like go a little bit deeper on rash and this macular papilla and petechia. I really like the way that you did the differential between them. But yeah, definitely on the diagnosis would be, I wanted to also say like there are drugs that can cause drug eruptions, DRESS, for example, the DRESS syndrome. And on viral, I could think Epstein-Barr also causes a maculopapular rash. And aside from the leptospira, typhus and rickettsial or typhoid fever, because I always had like in my student years, the difference between typhoid fever and typhus, murine typhus was like, I couldn't make the difference. But yeah, definitely what to say. And on the non-infectious side, I will also put this HUS, ITP, and TTP in the diagnosis. I think in this past weeks that we had so many issues with platelets, that would also something that I will be looking at. What do you think?
Absolutely. Now that we have a bit more time, we'll have, I think Henry's logged on to our other student's laptop, Carly, who's also joined. The parotid gland enlargement, I didn't really pay much attention or put too much weight on it, but now we have maybe spend 1 minute on trying to integrate that into this and see if we can come up with maybe some illness script that may define both of these features, the rash, the lymph, may not be lymph node enlargement, but parotid gland enlargement, altered mental status, rats running around. So with the parotid gland enlargement, usually Ravi, I think there was a recent VMR where he defined, is it unilateral, bilateral, unilateral? You can then think about the anatomy of the mouth, dental abscess, and so on. But in this case, we have bilateral parotid gland enlargement. Are we dealing with maybe an infectious etiology, HIV, mumps could cause bilateral parotid gland enlargement? Then you also have to think about autoimmune phenomena. So vasculitis could also cause Sjögren syndrome. So a few things to think about causing bilateral, possibly parotid gland enlargement or lymph node enlargement. So, I think let's look at the labs and see if we can narrow it down to maybe one of these disorders that we described here. So, Henry, we're good to go with the laptop now on the next aliquot.
Sorry about that. Okay, so the notable labs. So her white blood count, and this is all the initial labs that she got first in the ED. Her white blood count was 12.9, so mild leukocytosis. There was no left shift. There's about 1.0% for immature granulocytes. She had a hemoglobin of 7.8, a hematocrit of 21.9, and a low platelet count as well at 119, so mildly low. And then her chemistry was also done. She had a sodium of 152, potassium of 2.9, bicarb of 27, a BUN of 36, creatinine of 1.6, and glucose of 100. At the same time, the ED sent quite a bit of additional lab work. as they were unsure of what was going on as well. They had a liver panel that was done. She had an albumin of 0.3, an ALK phos of 720, an AST of 30. Her ALT was around 20, and her Billy was total Billy was 2.3 with a direct Billy of 0.7. She also had a lipase of 122. She had a VBG done that was normal. She had a carboxyhemoglobin that came back as normal as well. She also had a TSH that was done and was normal. She had an ammonia level that was done, and that was 16 and normal. She also had Tylenol, ethanol, or alcohol, and blood salicylate or aspirin toxicity that was negative. And she also got a UTOX that was done quite quickly, and it was only positive for methadone. Additionally, she had troponins done in the ED. She had a troponin of 1.75, and for our reference is less than 0.04 as negative, so positive troponin. She had an INR of 2.1, a PT of 20.9, and that was elevated, and a PTT that was normal of 26.1. And then the last lab that was done urgently was a urinalysis. They had catheter, and it was really foul, turbid, lots of leuk esterase, nitrites, white blood cells, red blood cells, but no bacteria seen, and no casts were seen.
Wow, incredible, Henry. There's a whirlwind of information there. I'm kind of like trying to get my mind wrapped around some of these parameters to see where we can put our cognitive energy into trying to get the diagnosis. But Yasmin, you want to tackle the CBC? I'll tackle the chemistry.
Of course. First of all, I'm looking here at a mildly elevated white blood cell, which could, do we have any differentials on the white blood cell? Like if it's neutrophil, eosinophil? Well, anyways, I'm thinking.
Yeah, I don't remember what I think it was more neutrophil predominance, no elevated lymphocytes. I think that was in the diff, yeah. Perfect.
So I'm not going, again, I'm trying not to anchor an infectious disease, but there is something causing inflammation. While it could be infection, there could be something else going on, and her hemoglobin is going down. So obviously we'd like to know if this is chronic, if this microcytic anemia, but hematocrit is 20.9. So I'm thinking this patient, it could be for malnourishment. They found her lying around after a wellness check. It might be very well something nutritional, or what if she is bleeding? I wouldn't discard that possibility. Something I am looking at, her platelets are, I'm not remember, this is low, if I'm not wrong. So I'm also thinking, what is going on with the platelets? Is it a consumpting? Is it reactive? And this could be the origin, the source of our petechial rash, because ITP, TTP, as we all mentioned, could present with it. So I would like to know if there is something going on with these platelets too. And I will leave the chemistry to you, but I'm looking also that if there are not issues with the liver, the main thing I will look at is the hypokalemia. Here is like if I'm not wrong, severe hypokalemia is 2.5, and that's a big no-no. So there's something going on here too, electrolyte-wise. But what do you think?
Absolutely wonderful breakdown of the CBC. You're right. The white count is pointing towards possibly a pyogenic infection here, maybe bacterial, but we don't know. It could be a marker of inflammation. The platelets are interesting. There is thrombocytopenia. We don't know if it's primary or secondary. So is it a bone marrow disorder? Is it due to maybe liver disease, sequestration, consumption? So it's kind of early at this point. I would look forward towards some coagulation parameters too. But then we hit the chemistry, and obviously sodium is possibly due to a dehydrated state. And we would have to see then if the patient has, say, for instance, is this a case of maybe diabetes insipidus, volume loss to cause a hypernatremia to this degree. And then also looking at the BU and creatinine, there is signal of renal failure. We don't know if there is pre-existing, if the creatinine was elevated before, if this is acute kidney injury, if this is pre-intrarenal, post-renal injury. And then what jumps out with the liver enzymes are the alkaline phosphatases dramatically increase. And then you have to start thinking, what are the most common causes of ALP, more isolated ALP elevation? Of course, ALP we find in the biliary canaliculi of the liver. Then we also have to pay attention to extrahepatic cause of alkaline phosphatase elevation, then namely bone, there's placenta, and then there's the intestine as well. But majority of times, I think about 80% of liver liver illness is responsible for ALP elevation. And then I think also you can get from kidney injury as well. Malignancy also comes into play. So I'm not quite sure what's going on there. We do also have some indirect hyperbilirubinemia. They're mild, but the patient wasn't exhibiting signs of jaundice, right?
Yeah, so that was interesting. She didn't appear jaundiced in the ED.
Okay. So I think with that level, there should at least be scleral icterus, but we're not seeing scleral icterus here. And then again, this is the index presentation with chemistries at the beginning. So later on, there could be an elevation in bilirubin further down the line. And then thinking if there is liver involvement, is any chronic liver injury or a process that's affecting the liver, the albumin may be extraordinarily high, maybe this could be hemo concentration, but we'll see. But the albumin is normal here. And then lipase is not super elevated. So again, thinking about intestinal causes of ALP elevation and lipase, but then again, visiting the indirect hyperbilirubinemia, could this be hemolysis? Again, AST is not elevated, LDH would be elevated. Then we look for the, somebody had put in the chat, TTP as a cause. That would be a great thought. Is there hemolysis at play here? And then there would also be other liver-associated conditions like Gilbert syndrome to think about as well, and Crigler-Najjar in that case as well. But troponin, you do have coags at the bottom. There's a lot of data to come through. So the INR is elevated. So is there pathology within the liver? Is there a coagulopathy at play? Is there, with INR being elevated, PTT is normal, so we're particularly affecting the extrinsic pathway there. So vitamin K dependent factors would be responsible for that elevation. So again, I'm sort of like, it's a toss-up. My mind is running between liver issues, or if something's external, maybe in the intestine. A few of the variables are indicating possibly liver, but the pattern doesn't fit. I don't want to force a diagnosis at this time, but we got skin, possibly hepatic, with signs of dehydration, maybe a pre-renal AKI, hypernatremia, and altered mental status. The vomitus may be a secondary or maybe a sequela of this. So at this point, I'm not going to pay too much attention to this. But Yasmin, any thoughts? Trying to juggle all these different things to consider a unifying diagnosis here.
Yeah, I'm definitely there with you. Like, I saw this isolated, the thing that caught my attention was the alphas, the isolated alphas. And of course, I would think about, well, the first differential diagnosis, an isolated alkaline phosphatase. I would think maybe something in biliary tree. This patient is on the same age of primary biliary sclerosis cholangitis. Although I don't remember, maybe the ones that are going to the step 1 is more, I don't remember if this is more prevalent in men or women. The thing is, if we don't have any issue, like she doesn't have any pain, I will definitely look for GGT, AMAs, IgMs to see if there is not an hepatobiliary issue or any other, or I should go to another workup. That's something that really caught my attention. But after that, I think that you really covered everything. And as well, the platelets, I would definitely think of ITP or TTP. That's still my diagnosis.
It's so wonderful to co-discuss with you, because I'm sort of springboarding from what you're telling us here and describing and presenting your mental model here, and it's triggering a number of thoughts in my mind. And what I would like to see is, if we were exploring liver as a possibility, then I think additional tests, maybe gamma GT 5-nucleotidase, may help us to then focus in on the liver as a possibility, and then decide if this ALP is coming from the liver. And I forgot to mention, but while you were talking, it did trigger, what about space occupying lesions? As we know, in various VMRs before, we've had infiltrative disorders, maybe something like granular metastases, malignancies, infections, abscesses into the liver, and space occupying lesions actually will cause a liver enzyme pattern where ALP will be much greater, many times greater than AST and ALT. So that's something I'll sort of throw into the mix here and consider as a possibility. So imaging will also be the order of the day here. So we'll like to see what kind of imaging Henry can also present. So I think, as people have mentioned, maybe I'm seeing blood film. So malaria possibly could be a thought here. The American version of malaria would be babesiosis up in the Northeast, but it doesn't have a predilection for the liver as well. So we wouldn't really consider that as well. But I think imaging and then some further blood tests, specialized, may be helpful in this case. But back to you, Henry.
Okay, so in terms of imaging, the first thing was the EKG that was done, and that just demonstrated sinus tachycardia. There's no axis deviation, no wave abnormalities, and no ST segment elevation or depression. She had a chest X-ray done that did not demonstrate any cardiomegaly. There was no pulmonary edema, no consolidation seen on that, and no pneumothorax or sort of pleural effusion. And so the emergency department decided to pan scan her with IB contrast. So they got a CT chest, abdomen, and pelvis, and they did a CT scan of every single extremity as well. Her CT chest demonstrated maybe some small little tree and bud nodularity in the bilateral lower lobes. However, there's no significant consolidation or interstitial infiltrates in any of the lobes. Additionally, she had some maybe circumferential wall thickening in the esophagus. Otherwise, the CT chest was unremarkable. Her CT abdomen and pelvis was only notable for maybe a little bit of peripancreatic fat stranding. And they suggested correlation with the lipase. And her musculoskeletal CT was negative. They also did a dry CT of her head, did not demonstrate any intracranial bleed, masses. They did notice a small area of encephalomalacia that radiologists managed to find an older CT of her head, which was unchanged from prior. So there were no acute changes in her head relative to prior imaging.
Henry, such a great presentation. I really appreciate you presenting this really complex and very intriguing case here. And the imaging that you presented here actually rules out quite a few things, but this tree and bud appearance on the CT scan, and again, she oxygen-wise 100% room air, and when you did the pulmonary exam, pretty much normal, but this tree and bud, there are a certain number of conditions. I know TB stands out to me that I've seen this pattern in, but it can be any number of bacterial infections, parasitic, fungal, viral. So I really don't know what to pin the cause of this on, or is this really a detractor here? Is it really going to help us lead to the diagnosis? So I think the cognitive strategy will be to keep pushing through, maybe look at those specialized tests. Do we have although this testing didn't specify any problems with the liver, this inflammation, this signal we're seeing around the esophagus and also the peripancreatic fat stranding. So the lipase was not particularly elevated, but there may be some process going on within this area that we need to look at closely. So is it worthwhile an investigation? I definitely think so. And again, when I mentioned the ALP elevation, again, intestinal disorders come to mind. So definitely would have to see this. Then how to integrate that with rats and all the different things, I have no idea, but let's see, in this rash here. So maybe we need to think about systemic disorders. I always think about the mimickers. HIV definitely is there. Sarcoidosis is there. You can get skin disorders with that too. The face lupus pernio, that has a violaceous kind of a border. But then systemically, I don't know. Amyloidosis is one as well, and lymphomas, leukemias, and we also mentioned TB, syphilis. So all of these I would definitely be entertaining at this point. Sarcoidosis, we mentioned amyloidosis. Yeah, pretty much all the mimickers that could present this way. Anything, Yasmin? I'm kind of lost here, but the journey so far has been very educational.
Yes, definitely. You have tackled the dream bot perfectly. I am learning so much. And if I'm not wrong, there are also like for this tree in bud images, you can have it could be obviously bacterial, viral, and fungal. And if I'm not wrong, one of the main bacteria that could cause this presentation could be Mycobacterium, especially tuberculosis and abium. So that's something that I would definitely take into my differential, without forgetting, of course, that also aspiration pneumonia can cause an aspiration issue can cause it. This person doesn't have any past medical history, but I remember that cystic fibrosis or even ciliary dyskinesis can cause it. Or think something more on the immunologic side, Sjogren's. This patient has a parotid gland enlargement, so I don't know. I wouldn't I wouldn't discard that so easily. Sjogren's or rheumatoid arthritis, sarcoidosis can present it, and obviously there are neoplasms that could present this way too. And now Henry also mentioned the circumferential wall thickening esophagus with together with the anemia. I would think, what if this patient also has Plummer-Vinson disease syndrome? And the peripancreatic fat stranding, but without a mildly elevated lipase, I wouldn't think of pancreatitis, but something more in the biliary tree, something happening in the biliary tree. That's something that I would like to look at. But again, if the PAN scan didn't show anything there, I wouldn't just like anchor on that. What do you think?
Yeah, I think there's a little bit of everything and trying to pull it together. I just want to mention I love Caroline's what she mentioned in the chat there, that her ID attending mentioned Mycobacterium or MAC could also cause elevated alk phos, can also explain this tree and bud phenomena. So have to look to these illnesses that can be systemic and attack all of these different organs that we have pondered on during our discussion here. So I think I've pretty much I'm going to sort of land my plane now and toss the mic back to Henry to see if there's any specialized testing that may reveal the diagnosis.
Yeah, so there's quite a few. So this is all the ED workup at this point. And so a lot of the specialized testing was done when she was admitted up on the floor, and then she ended up in the ICU. Is it okay if I give a sort of brief rundown from the ED and sort of what happened? So
Absolutely.
the biggest thought in the ED was at least ruling out some sort of meningitis at that point, because they, at this point, none of the toxicologies came back, versus some sort of sepsis. Even though her white blood count wasn't that elevated, she didn't have signs of vital signs instability. But they were really concerned with that. So they gave her extremely broad antibiotic coverage. She got vancomycin, cefepime. I think she ended up getting a dose of ampicillin and azithromycin as well in the ED. And then a neurology consult was done to do continuous EEG when she went up to the floor. And then shortly when she got on the floor, what ended up happening was within that same night, her mental status continued to deteriorate to the point where she was minimally responsive. She never developed hypotension needing pressors. She never developed any oxygen requirement. However, her hemoglobin just started downtrending to about 6, and her platelets just continued to plummet. And so she ended up being transferred to the MICU after receiving 2 units of packed red blood cells, and hemoglobin was still unstable. Now, most of the work now happened in the MICU, and some notable lab sort of findings was that her hemoglobin ended up going at a nadir of like 6, and her platelets had a nadir of about 13 for multiple days in the MICU, and received at least some platelet transfusions, and then cryoprecipitate as well. In the MICU, that's when all of the consults were called, where hematology had come in. They had done a full TTP, was really high on the differential, as well as some other micro angiopathic hemolytic angiopathies. And TTP workup ended all being negative, including the AMS 13 workup. They did a lot of specialized antibody testing that was negative. And then infectious disease was also consulted at the same time. And they gave a lot of recommendations for the labs. And I'll read about all of their labs in a little bit. Additionally, she also had specialized substance use disorder consult to really evaluate if there are any further sort of toxicology syndromes. And at the time, they were uncertain that any sort of withdrawal or any known substances at the time could cause that. Now, additionally, what sort of revealed sort of her big syndrome things was that her AST and ALT rose up to the hundreds in the MICU as well, and her INR continued to be high around 2. At that time, along with her vanc and cefepime were continued, and then she was started on doxycycline because at that time they're just worried about some sort of atypical, maybe spirochete infection. And just did empiric coverage for that. So now the last diagnostic step that they wanted, and someone was typing in, was a lumbar puncture. And so in the MICU, they attempted it twice. And unfortunately, both times in the MICU, she had, due to movement or she was just altered, they could not get a good sample of a lumbar puncture. And so in the MICU, they never ended up being sent, which was unfortunate. However, so at this point, I think the pathology came back, some sort of acute liver failure was very high in the differential. Hematology was, wanted to rule out DIC versus liver failure. And I think the distinguishing lab marker that they ordered at that time that figured out was factor VIII was elevated. He had high D dimer, low fibrinogen, LDH was high, haptoglobin, I think, was high as well. But the main distinction is that factor VIII was elevated, and DIC is a fully consumptive coagulopathy. And so having a single factor elevated meant that it wasn't DIC. So infectious disease, also their workup, they recommended we had done bacterial, fungal, mycobacterial cultures. All that was also pulled too before she got her antibiotics. She got basically almost every single virus known PCR done, HSV, CMV, VZV, HIV, all the STD panels, syphilis as well. She had enterovirus, she had LCMV, and had some other hemorrhagic fever and some dengue fever labs as well just done. And then they did a lot of the atypical infections like with the leptospira was one of the classical ones we were all really worried about because liver AKI and the thrombocytopenia. And they did HIV, hantavirus, they did babesia, ehrlichiosis, and a plasma, or archibound spotted fever. And over the next couple of weeks, all that lab did come back, and some of it came back quite quickly. Every single infectious disease was negative, and there was no previous hepatitis infection workup as well. She had no Hep C, no other hepatitis virus that was kind of given. And so she eventually stabilized, although it was quite interesting. About 2 days after she got the doxy in the MICU, she just suddenly appeared to start getting better. However, again, all of the infectious workup was negative. Eventually, she got downgraded to our floor and spent about 2 weeks on our floor, where we really took care of her, and her mental status improved drastically day by day. And I think the thing that kind of sealed the differential diagnosis and kind of told us was about 1 week on our floor when she ended up, suddenly remembering things and being back to baseline. She said that right before this happened, she bought some new substance off the street that she ended up smoking and then passed out and then woke up in the hospital. And so the last lab workup that was done and sent out from there was we had a meeting with a toxicologist that ended up doing some rare synthetic cannabinoid screens. And, I think those were still pending, but the working diagnosis at the time was that she had some sort of unknown synthetic cannabinoid toxicity that caused acute liver failure. And that's what caused her massive thrombocytopenia, her low hemoglobin. And this was also on the basis that all of her labs, including the mycobacteria and all the things that had sort of come up over the next couple of weeks, were negative. So that was the working diagnosis for this patient. The final diagnosis was some sort of synthetic cannabinoid toxicity that was not picked up on any UTOX or other sort of initial toxicology screening.
Wow, Henry, incredible. We kind of read through so many possibilities. I really appreciate you describing the course and how such a complete workup was done. And I think that was probably what I would have done if I was in your team's shoes, and really trying to explore all the possible devastating causes for this. But it all boiled down to what the patient was taking. And remember, we kind of stopped at the medications, also then stopping at the social history and behavioral history, all the substance use disorder that may be involved with this patient, having to think about that. And we've seen many times we've had patients present with narcotics that were mixed with, say, with the glyburide. I had a patient came in with hypoglycemia due to narcotics mixed with hypoglyburide, or cocaine with levimisol, and a patient developed a vasculitis because of that, or cocaine that was mixed with warfarin, having a coagulopathy. So it's not uncommon to have maybe cannabinoid, and especially these synthetic cannabinoids can do all sorts of different things to the body. So it's also certainly prudent to explore all of those possibilities, and also checking around the city to see if other people have had these reactions. So incredible case. I learned so much. I learned about all the different kinds of infections that can cause some presentation like this, but definitely it pays dividends to explore the health-related behaviors and medications to see if that may be causing a sort of presentation which doesn't fit one particular category. So a great clinical reasoning exercise. Really appreciate you putting the time in an expertly presented case. Yasmin, any reflections?
This is an amazing case, like definitely. And I learned something very important from here is like definitely ask the patient that without any judgment, with a very open mind, like if they are using something new, because I definitely didn't know that there were synthetic cannabinoids like around in circulation. And also maybe another thing that I can get out from this case is whenever I look at some tree and bud in the lungs, I can think of this talcosis, that it's a granulomatous response with due to the microcrystals that are sometimes in the drugs, inhaled drugs, or even with intravenous drug users. So maybe that could be a clue. But definitely, I think that I would have to update what is circulating on the streets so we can catch this much easier. Thank you.
Yeah, thank you, Andrew, for that case. Yeah, I thought with the doxy on board, I was waiting for maybe some rickettsial disease there, but it was sort of hanging off your every word there. So incredible case there, and definitely learned something today. Deborah, could you take us home with the teaching points?
Yeah, thank you so much, Henry, for presenting this case. It was really good. Thank you, Ravi and Yasmin, for the discussion. I will go for some quickly teaching points. So the patient started with AMS, and Yasmin went for our mixed mnemonics for the ABCDE. We have to check the vital signs, do a metabolic panel, look for the medication, drugs, alcohol, if the patient had any signs of infection, and the patient had a past medical history of opioid use, so maybe it could be like a opioid syndrome, if the benzodiazepine could cause like the AMS. And in the exam, we thought about the rash. It could be something inflammation or systemic, could be like the petechia for a small vessel vasculitis, a capillary fragility, a thrombocytopenia, or something like an infection like syphilis, HIV, Epstein-Barr. And in the labs, the patient presented really a lot of abnormalities, but one that we saw a pearl on the chat that alk phos elevated could be a cause of a MAC. That was like a really good pearl for me. And we went for the mimickers that Ravi said that was HIV, sarcoidosis, lupus, amyloidosis, lymphoma, leukemia, TB, syphilis. and rheumatoid arthritis. And in the end, we saw that the patient had a synthetic cannabinoid toxicity that could cause like a liver failure, something that I definitely have to read more about it. So thank you so much, Henry. It was a great discussion, Ravi and Yasmin.
Thank you, Deb, for this amazing teaching points. And again, thank you, Dr. Ravi, for allowing me to discuss with you. And I believe that I have learned so much from you all. And yeah, something else you want to add, Dr. Ravi?
Oh, no, I appreciate you willing to take this journey with me through this case that was spectacularly presented by Henry. So I appreciate everybody for joining. I hope you all learned everything, and we'll see you back tomorrow for another episode of CPS VMR. Take care. Have a great rest of Tuesday. Bye.
Bye, guys. Thank you. Thanks so much.
Thank you, Henry.